It is a huge honor for me to be interviewing a rock star in oral cancer. Lauren Levi, did I say, is it Levi?
Levy.
Levy, okay. Levy. I don't think the New Orleans people want to be reminded of Levy, but Levy. This is so interesting to me because at my age, when I was in dental school, I graduated in 87, you just thought oral cancer is just people who smoke and drink. And I always thought that due to a judgmental society, it's almost like you had it coming. You smoked a pack a day for 40 years. What were you expecting?
Right.
And I never heard once in dental school about human papillovirus. But now that's kind of been a game changer in oral cancer. I mean, we don't look at oral cancer as just smoking, drink. We've had a couple of really famous movie star, Michael Douglas, who actually said a word on a TV that I didn't even know they'd ever play, and he got it from oral sex. And then there's a very famous football player from the Buffalo Bills who's got oral cancer, and they're basically just insinuating this wasn't from drinking and smoking. I don't think he's come out and said anything. So first of all, thank you for being on my show. And
thanks for having me.
Oh, you got an hour with thousands of dentists. Like saying, I think the last podcast had 7,000 listeners, and they're mostly all commuting to work. What do you think they should be thinking about when they think of oral cancer?
I guess just like what you were saying, that you would always just think of those traditional people of the older men that were smokers and drinkers, and don't think that. It doesn't take a very long time to do an oral cancer screening, even though it might seem like it's not important. It really is. And it doesn't take a very long time to do a thorough history taking. So don't forget to ask those crucial questions, even if some of them might be a little uncomfortable. Don't assume anything.
Okay, verbalize an oral cancer exam.
Verbalize? So you mean like in terms of history taking, or what you actually do?
What do you actually do? I mean, I think about 85% of my listeners are just audio only. They're just listening to this while they're driving. So they can't see you get a patient and do an oral cancer exam. So you just have to talk them through it. Because a lot of people who I see when I'm standing behind a dentist, and I say and I see him do the oral cancer exam, like some feel around their field. The 90% are looking inside the mouth. I mean, in all honesty. I mean, really, I don't see my buddies touching them. They're looking. So walk them through an oral cancer exam.
Okay. So first, you definitely want to palpate the head and neck extraorally. You want to make sure you're not missing any, lymph nodes or glands. Have them turn their head to the right and the left, so you're feeling along the sternocleidomastoid. Really, and don't be afraid to pinch, because I feel like a lot of times, at least initially, people get scared and they do a quick little feeling and then you don't feel anything. But you have to really go for it and palpate. And then you also want to go up and make sure you go behind the ears and in front of the ears as well.
Really? Behind the ears?
Yeah,
Yeah?
Yeah. Well, you're just lifting your, here. And then I always, palpate their lips, of course. And then you go in and, like everybody does, you take that gauze, have them stick their tongue out, pull their tongue, look to one side and then look to the other, look in the back of their throat, have them lift their tongue, dry the floor of their mouth a little bit, look there carefully, and of course look at the palate, look at the vestibules. It doesn't take a very long time, but it obviously makes a huge difference. And
what I'm reading is one person dies every hour of oral cancer in just the United States alone.
It's horrible.
And so then I got to ask you, as a woman, instead of man, how come if you go to a doctor and ask for exam downstairs, the insurance pays, and they can use, they can do a uterine pap smear, all that stuff's paid. But when I do an oral exam or oral cancer screening on a female in her mouth, most of the insurance don't even pay. I mean,
that's a good question. Yeah, I don't know.
Isn't that kind of bizarre that the lower half of your body is worthy of an insurance reimbursement and the upper half of your body is not?
No, well, I think that still goes back to the theory that people think that the mouth is not connected to the rest of the body, and a lot of stuff in the mouth is not covered by medical insurance.
Okay,
right? Don't you?
yeah, I mean, absolutely. I think that the Soviet Union did it so much smarter, where stomatology was just a branch of med school. You know, the first 4 years
Right.
undergrad the same, then 2 years, and you wanted to be a dermatologist, and your buddy wanted to be a gynecologist, and your other buddy wanted to be a stomatologist. And what I like the most about that system is if you ever decide you're not good with your hands, you only got to do another residency and you go into some other branch of medicine. Whereas dentistry, you got to start all over and go to med school.
Yeah.
I think that was, I think it should be corrected. I think they
I
should,
agree.
but because you need, you know, in economics, we like fluidity of markets. We like a continual 5% unemployment, shifting people from lower productivity areas to higher productivity areas. And I think healthcare would be better if nurses and hygienists and dentists and physicians and everybody could move around with more fluid than having all these artificial barriers to entry, which is crazy. Okay, a lot of dentists are thinking, well, to do an oral cancer exam, I hear of all these products sold, Velscope, toluidine blue rinses, all these things like that. Should I be incorporating that stuff into an oral cancer exam?
You know, the studies on those are mixed, so I would say no. I think still the gold standard is just using your eyes and hands, and if you see something suspicious, biopsy it. Of course, there's always that rule of wait 2 weeks, but if I see something very suspicious, I'm not waiting 2 weeks, because who knows when the patient came in.
Okay, well, you're a lot smarter than me or any of my listeners on the subject of oral cancer. I can assure all my listeners of that. I doubt I don't know who would be listening that would know more than Lauren on this. What if I'm palpating something? Um, Talk about what I would be feeling that would make me suspicious. I feel a bump, or is if it's
Is it movable?
Okay, talk about that.
Right, so is the bump movable? If it's not movable, that's of more concern. Is it indurated? That's, of course, of concern.
Is it what?
If it's indurated, if it's hard. So if it's not movable and if it's indurated, those are two key areas of concern. And then
If it's not, so is not movable and are you saying indurated?
yes.
Indurated means not movable, a fixed.
No. Indurated meaning hard. Indurated means hard. And then if it's not movable, if you feel, when you're feeling someone's neck, you always feel a lot of lumps and bumps. That's normal. Those are just lymph nodes. Sometimes they might be enlarged because the person has allergies or they were just getting over a cold or they were sick. I always ask all of those questions if you feel something. Say, oh, do you have allergies? Were you recently sick? Do you feel like you're getting sick? That sort of thing. If they have bilateral enlarged nodes, then it's not as much concerning, of course, than if it's one-sided. Granted, it could also be that it already spread, but most likely that
what if when you pinch it, it hurts, it's tender? Is that more likely or less likely to be not good?
Cancer usually doesn't hurt, but I wouldn't rule that out, and just because it hurts, I wouldn't say it's not.
So if you feel a hard bump and you can't roll it around and it feels like it's fixed, that's bad because
absolutely.
Because fixed means it's metastasizing, so it's attaching to something.
That's a good way of. Yeah, no, I mean fixed. Just usually when it's fixed, it's usually malignant, or it's not. It's not just a normal lymph node that's draining because you had an infection or something, or it's not most likely a benign cyst. It's something of concern.
And okay, now so let's go from your fingertips to your eyeballs. When you're looking in the mouth, what are you looking for? What concerns you?
So most things in the mouth, don't really come in that many colors. They can be blue, they can be red, they can be white. Pretty much it, right? So if it's something if it's an ulcer that looks like it does not heal, and the patient said it has not healed for a while, then that's, of course, something to be of concern. Granted, a lot of times you can have an ulcer in the mouth, and it could be a lot of things. But if it's a non-healing ulcer, that's something to be concerned of. If it's more white than red, or if it's mostly white, that's less concerning than if it's red. So, I think the statistic is like 85% of leukoplakic lesions, 85% are just benign keratosis. So that means, they have a good shot of that being nothing. But if it's red, if it's like erythroplakia, it has almost 100% chance of showing some sort of dysplasia. So that's something that's more concerning.
So then white is better than red.
Yes. It could be white and red, but yes. But just white is not as bad as red. Exactly.
So basically, the American flag, red, white, and blue, is pretty much could be all bad.
Yeah. Yeah, there you go.
Maybe the American flag needs biopsy. So when something's suspicious, do you think sometimes you hear people saying that the way the dentist did the biopsy, he messed up the diagnosis, and sometimes you hear oral surgeons complaining, "I wish I could have done the biopsy instead of you." Is that territorial turf protection, or is that legit? If a dentist sees something bizarre, should they biopsy it and send it into a lab, or do you think they should send it to an oral and maxillofacial surgeon to do the biopsy?
I think if they feel comfortable doing the biopsy, there's no reason that they can't do the biopsy. If they don't have a lot of experience doing the biopsy, then they might want to send it out to someone that does it more regularly.
And talk about what you like to see in a biopsy. Do you like to cut out the entire lesion?
It depends. It depends on how big it is. Always take a picture first, no matter what, of the patient, and take a pic, of the lesion before you cut it. And then it depends. Like if it looks like it's something small enough that you can take the whole thing out, and that's great. Otherwise, if it's too big, make sure you also get normal margins, so that the pathologist has enough to compare it to.
Okay, and what is the average size of a lesion when you see these and they're bad? I mean, by the time it shows up.
That's a good question. So I actually see most of the time I don't really see patients before they're diagnosed. Most of the time I'm seeing patients and they've already had cancer. So, a few times I'm seeing them before the cancer has been treated, but a lot of times I see them and part of it has already been excised. So, I'll just think about like the last patient I saw who had cancer on his palate. I want to say he had an ulcer on his palate that was, I don't know, maybe 2 centimeters in diameter. Which isn't really.
Yeah. So HPV's the big buzzword now in oral cancer. Educate us on HPV.
Well, the thing with HPV is there are so many strains that just because you've been exposed to HPV doesn't mean that you have an increased risk of getting cancer. So I think it's important to know that it's only the higher numbers, 16, 18, 32, and that most people that are exposed to the virus actually clear it. So it's really only, I believe, 1% of people that are exposed to it that don't clear it that are at that increased risk. And right now, I think we've been seeing HPV-related cancers more commonly in younger males that don't have a history of smoking and drinking.
And why do you think it's males instead of females?
Well, the thought process is that it's related to oral sex and that the vagina can't clear the infection as well. That's what I think that's what the theories are right now, whether or not that's true.
Okay, males get it more because when they're doing oral sex on a female or on a partner, the vagina is more likely to have it in there because the vagina is not clearing it as well.
Right, that's the thought. I think that's the recent theory right now. Yeah, I don't know if that's true.
So we hear of the HPV vaccines. If you gave, like, I have 4 boys, should I send them? They're 20, 22, 24, 26.
So.
I should go get.
So. Yeah.
And what strains is the HPV vaccine good for? I mean, like a hepatitis. I have the hepatitis B vaccine.
Right.
I think that's the only hepatitis vaccine. There's not one for A, C, and D, is there?
There is one for A.
There is one for A?
It was new. It's like newly developed. I mean, not that new, but like newer since like you were born. I want to say like late 80s, early 90s. The hepatitis
I was born 2 days before Fred Flintstone. Now, what are your, so you think my boys 20, 22, 24, 26, they should get the HPV vaccine?
Yeah, I mean, I think what the CDC recommends is that you should really get the HPV vaccine before you're sexually active. So they're suggesting it in children as young as 9. But if they haven't yet been exposed, then I don't think that there would be a reason not to get the vaccine. I would advocate for everybody to get the vaccine.
So for your average 40-year-old American, what's the chance the vaccine wouldn't be significant because they've probably already been exposed to what the HPV vaccine prevents you from?
I don't know. I think probably like infectious disease control people would probably say it's a waste because they've most likely been exposed. But I guess you could do, you could take blood and see if there are antibodies to it.
And for my listeners, they're dentists, they're exposed to blood all the time. Do you think they should get this new hepatitis A vaccine?
Yeah, I mean, hepatitis is more, fecal oral. So it's more concerning if you're, going and eating in like a developing nation where you're concerned about the food, or if you're, maybe really into ethnic food and they're not washing their hands well, or something. I don't know, something random like that. Like, I mean, if you're traveling abroad somewhere and you're concerned, get the hepatitis A. I don't think it's as concerning for the dental office.
What if your dental office staff eats at Taco Bell?
I mean, then maybe you should be concerned.
I thought that was funny when I forgot the exact numbers when someone said, it's not beef because beef has got to be, it's not all beef. And the comeback was, oh, yeah, it's like 30-some% beef. I mean, it was not the response I was looking for. So I don't feel like I'm smart enough to ask you the question. I almost think you should go to a lecture. I mean, because you're a lead in this. So, I mean, like, what is dental oncology? What should my listeners be thinking about? Just take the floor, take it away.
Okay. So basically, dental oncology is treating the oral and dental manifestations of cancer therapy. So I did a fellowship at Sloan Kettering, and what I did in the fellowship, it wasn't just looking at people suffering from oral cancer, but it was really seeing patients before they underwent chemotherapy, before they received a stem cell transplant, or before they were receiving anti-resorptive medications or anti-angiogenic medications, some sort of medications that may result in osteonecrosis of the jaw. So it's really a combo of that. And then of course seeing patients that were undergoing head and neck radiation and or surgery.
And so when someone's being treated for oral cancer and we get them, sometimes we get patients say this person's going to get treated for cancer, and so fix them up first, and then we get people back from being treated with cancer and they got dry mouth. And talk about when an oncologist sends you a letter and says, Lauren's going to be treated for patients. I need her dentally taken care of by this date. Or versus the lady that comes back that had radiation in the head and neck, she's got all dry. Can you talk about those issues?
Sure. Okay, so if a patient comes to me before they're undergoing cancer therapy, let's say before they're undergoing radiation treatment, head and neck radiation treatment. So first thing you do is, of course, you do a thorough exam, take a thorough history, and you're pretty much beefing them up before their radiation treatment. A lot of oral hygiene instruction, heavy discussion with them about the risk of developing osteoradionecrosis of the jaw in the field of radiation, and explaining to them that if they need teeth extracted, now is the time to do it. Because after they're getting that high dose radiation therapy, you're not going to be wanting to perform extractions in the field where the radiation
and is that for the rest of their life?
I like to say for the rest of their life. And I think it's also important to remember and to also explain to patients that radiation, it's a beam that goes through. So even if the cancer is on the right side, if it's the right backside base of tongue, for example, you have to remember that the radiation goes through. So the left posterior teeth are also going to maybe be affected, and those teeth should also not be extracted because the beam went through and touched those teeth. So after you do that and, you take out the teeth appropriately and, you clean them up. And I also suggest doing, a prophylaxis before. The next thing is to look in their mouth and see if they have a lot of metal restoration. So if they have amalgams, PFMs, that sort of thing. And then you would make something called a radiation mouth guard, which is preventing the backscatter from the radiation.
Wow, so, you're almost making a case to go for the future generations for dentists to go metal free.
I don't know if I wouldn't say take them out. I would just say, I wouldn't say take them out. I mean, I don't love amalgam, but that's irrelevant. You're not going to be doing a full mouth rehab because they have cancer and they got to get in, Basically what you're just saying is if they have metal restorations, if they're intact, there's nothing wrong with them, You just want to make a mouth guard that protects the radiation. And we don't even really know how accurate this whole backscatter is, but the thought process is that the radiation hits the metal and scatters and may produce mouth sores.
So how does a dentist make this metal mouth guard?
It's just a very like you can. It's pretty much like a vacuum form. It's like a night guard. It's soft, but it's very thick. If I had one on me, I would show you. It's just a very thick, clear, thermoplastic material.
And so a thick, clear. And what is it doing? It's helping the radiation not hit the amalgams and PFMs.
Yes. Yeah. The thought process is that it's kind of like a radiator cover, so that when the radiation touches, it most likely it won't hit the metal and bounce off and scatter onto the mucosa and cause mouth sores.
And what is it made out of? The same stuff we make a night guard, or is it made out of?
Yeah, it's the same. No, it's the same stuff. It's just very thick.
Interesting.
The thickest you can find, pretty much.
I'm really hoping you make this is so important with an American dying every hour. I really hope someday you make us an online CE course
it's a great idea.
That we can play an stabbing to the dentist, the hygienist, to get the whole team on board about, I can't believe there's not even as much media coverage about this. Seems like there's a lot of it in the United Kingdom. It's a much bigger story in the UK where they're calling it mouth cancer.
Right. No, it's a much bigger story for some reason in Europe in general. I don't know. The U.S. is a little behind the times with this for some reason.
Yeah, it's different. And by the way, back to the doctor stuff. The dentists are always saying, sometimes Americans will say, "Well, you're a dentist, you're not a real doctor," and the dentists are sensitive to that. They say, "Oh, I am a doctor," but I have to ask themselves, are they really a doctor if they when geriatric people come in your office and you don't even give them a flu shot? But I can go to Walgreens or CVC and a pharmacy tech will give me a flu shot. Shouldn't a dentist be giving an HPV vaccine or discussing to mom, hey, your daughter's, your children are pre-sexually active, which in Arizona would probably be 16, in Kansas it'd probably be 12, and that was a joke. And,
I know.
But how come? But if we're real doctors and the average American sees a dentist twice every time they see a physician, shouldn't we be given flu shots and HPV vaccines?
Absolutely. I think that would be a great idea.
So why don't dentists demand the right to have the same right as the pharmacy tech at Walgreens? When you go to Walgreens to get a flu shot, the pharmacist doesn't do that.
No, you're right.
Tech, and the tech didn't go to. The cashier didn't go to school, but the pharmacy tech went to school. But I just don't get it why we're not the leaders in flu shots and HPV vaccines.
Absolutely, especially because they're intramuscular. The injection technique in comparison to a dental injection technique, I think, is much more straightforward. What anatomy are they hitting when they're hitting, right? It's true.
So where is the HPV vaccine and the flu shot best given? Just in the arm, the deltoid?
Mm-hmm. Yeah.
Yeah. So it'd be pretty simple.
Yeah, I think so. I don't think it'd be very complicated.
Yeah, and you know what, I think Tennessee's the first state that is leading this issue on dentists should be given HPV vaccines.
Really?
And flu shots. Tennessee.
Oh.
They invented Jack Daniels, and now they'll be the first to come up with the flu shot. And dentists have to demand that. I think it's time for dentists to decide: are you just a high-tech lab man because now they got their Cerac machine and they're scanning and milling? And are you just a glorified lab tech? Or are you a real doctor? Are you a doctor of the mouth? Are you a physician of the mouth? Are you a stomatologist like in Russia and the Ukraine, which is really, when it comes to dentistry, advanced?
Absolutely.
And, far more advanced than us. So what else do you want to talk about? What would be the best use of your time right now with my listeners talking about your specialty? Oh, by the way, when you said Sloan Kettering, congratulations on that. That's like one of the top 4 most elite cancer hospitals. I just think of Sloan Kettering. I think of the Mayo Clinic. I think of the Houston. And Sloan is from an idol of mine. Alfred Sloan was the founder of GM. And, Henry Ford had the whole market with one car. You could have any color you want as long as it was black. And it was actually Alfred Sloan who came in and offered price segmentation and said, Henry's got one car. But what if you don't want just the $668 car? What if you want to pay a little, and we'll have the Chevy compete against that, but we'll pay a little more with the Pontiac, and we'll have the wheels come off, and we'll have a little more money for the Oldsmobile, and it'll have a roof over it, and we'll have a little more money, and we'll have an automatic starter deal, so you have to go out there and wind it up. And the Cadillac had a roof, removable wheels, an electric starter deal, and the craziest thing that they ever did, a little company called Motorola was making a radio for a car, and Henry Ford laughed at Alfred Sloan, and GM ended up slaughtering Ford, and he closed down his assembly line, and he donated a huge bunch of money for the Alfred Sloan Kettering. But I'm embarrassed that, who's the Kettering guy? I'm embarrassed I don't know the story of that founder.
I didn't even know the story that you just told, so I don't know.
Oh my gosh, you went all the way through the Sloan School and you didn't know the story of Alfred Sloan? You got it. I'm telling you, it would be a crime against humanity if you went through his foundation and didn't read My Years at GM by Alfred Sloan.
All right.
It is just a walk through economics. And then when you do our online course, you're going to have an opening. Tell us who the Kettering guy was.
Absolutely.
Or email me his first name and last name so I can look it up, because obviously he had a ton of money and he was a good guy leaving it for cancer. But what else do you think you learned in your training that the general dentist like me doesn't know and should know and should think about?
So I think one thing that initially when I was there I didn't think of, and now it always comes to mind, is if a patient tells you they have breast cancer or prostate cancer, always ask them, is it metastatic? And if so, did it metastasize to bone? Because if it's metastatic and metastasized to bone, they're most likely going to be on a bisphosphonate or denosumab. And as we know, both of those drugs, well, I guess bisphosphonate is a group of drugs, but those anti-reductive medications are associated with osteonecrosis of the jaw.
Okay, explain. You said bisphosphonate.
Right, bisphosphonates. Right.
That's the generic name. Are there any brand names?
Yeah. So bisphosphonates are those huge, that giant class of drugs that include Boniva, Fosamax, Aredia. Pamidronate is the generic name. There's Actonel is another one. Some of them are oral, some of them are IV. A lot of the U.S. population is on them orally for osteoporosis or osteopenia, but what's more concerning are patients that are on them IV and have a history of cancer or being treated for, metastatic disease to bone or multiple myeloma.
And what was the other one?
Denosumab, which the trade name for that is Xgeva or Prolia. Prolia is for osteoporosis. Xgeva is the one for cancer, usually.
So if a patient is on those drugs, what red flags pop up? The dentist should not be doing extractions. Talk about
right.
what
no
changes.
Extractions, no implants, obviously, no bony surgeries, no deep. Be careful if you're doing even a perio cleaning. You don't want to be disrupting the bone because they're at risk of getting this osteonecrosis of the jaw, the area not healing properly. And I think it's really important to also tell patients, like the minute patients, tell you that they're on that, you have to explain to patients that they have to be careful not to get invasive dental procedures done.
So what if someone comes in and they're on that and they have to have an extraction? I mean, it's easy for me. I'm in Phoenix. I just dump it on my oral surgeon. I don't even want to deal with this. But
right.
What if you're the poor bastard oral surgeon? And
I wouldn't extract it. I would say that you can get the tooth can get a root canal and even get a coronectomy, and then you just seal it off to the gum line. I would not recommend extracting the tooth.
If they're just on the drug, or if they're on the drug and have cancer. Are you talking about if they're just on the drug?
It depends on how long they're on the drug for. So osteonecrosis of the jaw is more commonly associated with IV. 96% of the incidence of here's the annoying thing about this, that the incidence of osteonecrosis of the jaw is very low. So you obviously have to tell your patients and let them make the informed decision, but there is a chance of getting it, unfortunately, and the chance is higher if the drugs are IV. So if patients have had several doses of it and they're still maybe being treated, or even if they're not being treated, if they've had several doses, the half-life of bisphosphonates is 10 years. So the likelihood that it's still in their system is high. It probably is still in their system.
And did you just say 96% of the people who did get osteonecrosis had these bisphosphonates delivered IV.
Yes.
And when they get IV, how long is the IV in? I mean, they go to the doctor and they put them on an IV of this stuff and like.
Yeah, they go in, they get IV, they leave, they come back, they go in, they get it. You know, it's not like they're. Yeah.
And explain to the viewers what does that mean? So let's say someone did IV bisphosphonates, they pulled it through, they got osteonecrosis. What is osteonecrosis? Why is this bad? Because I'm sure most everyone has never seen a case.
Right. So.
What does it mean? A big area, your jaw's going to die, or?
Yeah, I mean, it's basically exposed bone in the maxilla or the mandible. It's more common in the mandible because of, that limited blood supply. Sometimes you can just see an ulceration. Usually you see exposed bone. Sometimes there can be separation associated with the area. And the real concern is that it can lead to jaw fracture, that if it propagates and then that's the major concern. And of course, infection.
So do you get patients like this? Or have you seen patients like that?
Yeah, I have, unfortunately.
So what do you do for them?
So to be honest, there's really not that much to do. It's really just palliative wound care. If it looks like it's an infectious process and there's separation, you prescribe them an antibiotic. But the concern with the antibiotic is that sometimes it can't penetrate because there's no blood supply getting to the area, so the antibiotic cannot get delivered. I always prescribe them chlorhexidine, gluconate. I do it alcohol-free. Tell them to keep the area extremely clean. You keep the area extremely clean and just kind of watch it. And hopefully the hope is that the bone will just exfoliate and that the area will just, the gingiva will just kind of epithelialize over.
What if your patient's Irish like me and they can't drink anything without alcohol in it?
I mean, I guess you could use the chlorhexidine with alcohol if you really.
Okay.
But.
Okay, good point. Good point. You're giving me faith. And this oral cancer exam, with HPV a side effect. I mean, we used to think of an oral cancer exam on grandpa and grandma,
right?
Especially if they check, yes, I smoke. Who should be getting oral cancer exams now?
Everybody. I would say, no one's excluded from that.
At any age?
Yeah, absolutely. You never know. I mean, but when you're doing the oral cancer exam, you're just looking for everything. It might not be you don't know what you're going to find, so it doesn't take a very long time to do that exam.
Okay, and so is oral cancer different if it's caused by smoking, drinking versus HPV as far as location of the mouth? I mean, is HPV more back of the throat, oral pharyngeal, and smoking, drinking more anterior lip, tongue?
Well, the most common site for oral cancer is still the lateral borders of the tongue, followed by the floor of the mouth and, Waldeye's ring area. But if you're doing snuff, it would be a good place to look would also be where they're keeping the snuff. That's what you're saying. But for the most part, it's still back of, lateral border of the tongue is still the number one spot of cancer. And
lateral border of the tongue could be from HPV or smoking and drinking, the location. So are you saying that HPV-induced oral cancer doesn't really so much change the location of the cancer?
Well, I guess they're all kind of in the back area, so no.
Okay, because some people, I've heard some dentists believe that they think HPV is more adenoid,
tonsillar,
back of the throat, as opposed to smoking and drinking more lateral borders of the tongue. But
I mean, I think that is true. I think you'll more likely, if it's HPV related, you'll more likely see it there. But I think the statistic still is that the number one spot for cancer in general in the mouth is the lateral borders of the tongue, if that makes sense.
I know a lot of people I'd like to prophylactically remove their tongue so that they don't ever get oral cancer. And then I get some other side. So I'm at 34 minutes. You only got 25 minutes left. What else? Like I say, I don't feel like I'm smart enough to ask you the questions for the day. I almost think this should have been just a lecture. What else did you learn after all your years of training that you don't think you knew when you were in dental school? What do you think you know that a general dentist doesn't know that they should be thinking?
What should they be thinking? Okay, so we went over the drugs for people to ask about because that's very important. Let's see. A take-home message, maybe, you're saying?
No, just what else do you want to talk about?
Well, what do you think is the most beneficial? Talk about maybe treatment options or?
Sure. Whatever
Okay.
you think.
Okay. So lately I've been seeing a lot of people that actually have graft-versus-host disease in the mouth. So basically I see patients, before they undergo transplants and as well as after transplant. And if you have graft-versus-host disease in the mouth, it's of course after they're getting a stem cell transplant. And basically it kind of looks like implantus. So it can be, it's like white. It's like a picket-like fence. It can be on the tongue, it can be on movable mucosa, anywhere. And the first thing to do is obviously to diagnose it. So what you do is you take a biopsy of minor salivary glands in the lower lip. So the conversation goes like this. So the oncologist might send to you a patient, say, I see something in the patient's mouth, I don't know what it is. Send them to you. You take a detailed history of the patient, find out that they had a transplant, take a biopsy of the lower lip, or I guess the oral surgeon did. Somebody took a biopsy of the lower lip, find out it's GVHD.
Find out it's what?
That it's GVHD, graft-versus-host disease. GVHD, so graft-versus-host disease.
Oh, graft-versus-host disease.
Yeah.
Okay. So like GV Black, graft-versus-host disease. Explain what that means.
So basically it means that the graft is attacking the host. So they got a transplant from they either got a transplant from somebody else or...
Well, what's the most common, a kidney?
Well,
what are they transplanting these days?
I'm talking about stem cell transplants.
Okay.
You can get it. You definitely can get this from a solid organ transplant, but I don't really see so many patients from solid organ.
Okay, so you're calling a stem cell treatment for cancer is actually a graft. I mean, it's from someone else.
Right.
So, I never even thought about this. That's why I'm telling you I'm not smart enough to ask you your questions. So stem cell treatments, graft versus host disease is now.
Exactly. So here's a summary of what happens. So a lot of patients that have a history of leukemia or lymphoma might be treated with a stem cell transplant. So they undergo high-dose chemotherapy. Okay. So first the oncologist will harvest the cell. I guess that's not really fair. So it depends. You can have a stem cell transplant from yourself, or you can have it from somebody else. If you have it from yourself, they'll take out the cells first. If you have it from somebody else, a stem cell transplant is a broad term for something like a bone marrow transplant. That might be, if you've heard of that. Basically what they do is they wipe your body you undergo high-dose chemo, total body irradiation, and so this way the body can accept these new cells that do not have cancer. And if you have graft-versus-host disease, for whatever reason, unfortunately, the graft is actually attacking the body.
And if you have graft-versus-host disease, just think GV Black, GVHD, there can be oral manifestations.
Yes, in fact, a lot of the times, oral manifestations might be the first manifestation.
Okay, so then talk about that. What are these oral manifestations, and how do you treat them?
So, dry mouth, this picket-like fence, ulcers in the mouth, sometimes even trismus, and feelings of muscle tightness and being fibrotic. And it's actually a pretty big deal because if it's localized to the mouth, that's okay. But if it's localized to the mouth and it's going to become systemic, graft-versus-host disease can actually be life-threatening. So you don't want to take this with a grain of salt. You want to treat it appropriately. You can treat it with dexamethasone rinse. I like to do Temabate with Orabase.
Hey, slow down and say those again. Dexamethasone rinse.
Right.
Is that you just call your pharmacist and tell that, or is there a brand name, or
right up? It would be dexamethasone 0.1% mouth rinse. The concern with that though is that it is a steroid, so you don't want them to be swallowing that. So my first line of defense usually is Temabate with Orabase.
Kenabase with Orabase.
Temabate.
Spell it.
Temovate.
I'm trying to figure out your accent. You went to Florida, but you're a New Yorker?
Yes.
Born and raised in New York?
Born and raised in New York.
Which part? Manhattan, Brooklyn, Bronx?
I live in Manhattan now, but I'm from Long Island.
Oh, Long Island. Okay. And okay, so spell it.
So, so
Say
it's
it again.
so TMOVATE.
Okay, and how's that different than dexamethasone?
Dexamethasone is a mouth rinse. The Temabate is a cream,
Okay.
and you have them, and it's with Orabase so that it sticks on better because otherwise the cream will just, you put it in the mouth and it's going to go everywhere. But if it has Orabase, it kind of, you tell the pharmacist to make it this way, and then you tell them to apply it to whatever lesions they have in their mouth.
And would a standard pharmacist at Walgreens or CVC do this, or do you need like a special
No, they will.
hypothesis?
Yeah, they will. You sometimes have to you have to sometimes call the pharmacist and make sure that they'll mix them for you. But yeah, it's usually not a big deal.
Okay. What are the individual pharmacists called? Hypa?
What?
I think Phoenix
Oh,
has
like those, like I know what you're talking about.
hypothecarius, or
Yeah, yeah.
hypothecary that just all
Uh-huh.
they do is the stuff that the big chains really don't really do.
Right. But I've never had that problem so far. I mean, because you can also just tell pharmacists to order things. Like
Okay.
sometimes, I will prescribe random things to patients and you just have them order it.
Okay.
Like the chlorhexidine, believe it or not, alcohol-free chlorhexidine gluconate is like a big, I don't know, it's not so easy to find. So you just have to push them and say, no, it actually does exist. It's a purple formula.
Well, now that you said that alcohol free, let me tell you an old school debate. Probably before you were born. I don't even want to know what year you're born. I don't want to ruin the rest of my day. But when I got out of school in '87, a lot of people didn't like alcohol mouthwashes because they thought that caused oral cancer. But then there were other people saying, no, it's when you're an alcoholic, it's what it's doing to your liver that's making cancerous stuff. So swishing with alcohol does not cause oral cancer. Drinking alcohol and having it broken down in your liver is what causes cancer. Is that true? False? What's the current? What are you saying? Current thought is?
I think the current thought is that you shouldn't be swishing with alcohol. That it could, I don't think it's confirmed. I don't know like what the studies are saying about whether or not it could actually cause oral cancer, but if alcohol is related to cancer elsewhere, why should you be swishing your mouth to something that might be related to could be causing cancer in your mouth?
So probably everybody wants to know, since you're an oral oncologist, what brand of cigarettes do you smoke, and what type of wine and whiskey and beer do you drink?
Very funny.
Very funny. So I take it that's a no across the board.
I mean, I drink alcohol socially, but I do not smoke cigarettes. Never smoke
Yeah.
cigarettes. Yeah.
But do you think a social drinker, like your drinking habits, do you think a social drinker, a moderate drinker, is at an increased risk of oral cancer?
Um, it's tough to say because there are some benefits to drinking some amount of alcohol, right? The resveratrol in red wine being associated with, reduced risk of heart disease and that sort of thing. But I don't know. I don't know if there's really that many studies that clearly define that. But I think
Yeah.
that would be a really hard thing to tell because I don't know how they would do a study by that. If it was a survey, will people really tell the truth about how much they
Yeah.
drank? Probably
I,
not.
I I think the key to all that stuff is moderation. I mean,
Yes, I agree.
yeah. And so I'm down to 15 minutes with you. What else can you educate all these dentists listening to you today on what you learned at Sloan Kettering that they probably might not know or should think about? I bet a lot of people are wondering right now just the human side of the story. What's a day like in your life? I mean, what do you do 8 to 5? Where do you work? Are you in a hospital? Are you in a private dental office?
I'm in a private dental office,
In
and
Manhattan.
in Manhattan, and I mainly see patients that are referred to me from oncologists. I mean, some people have found me online, but usually oncologists are sending me patients. A lot of these patients have a history of oral cancer, and the radiation oncologist will refer the patient to me before they undergo radiation treatment. And so we'll do a thorough exam, like I was saying before, work them up, beef them up, and then I take salivary measurements of them as well as a baseline because, as we know, radiation therapy can cause xerostomia and hyposalivation because it affects the salivary glands.
For
And
how long is that for the rest of their life? Does it
it
have
depends on
healing
the
potential?
yeah, it depends on the extent of how much radiation therapy. But if they're getting head and neck radiation therapy and it's going to be above 25 gray, the results will be irreversible. They might get some salivary flow back, but it probably won't be the same as it used to be.
Above 25 gray?
Yeah.
What does that mean in English?
Gray is just a way of measuring radiation.
Radiation.
Yeah.
Huh. What if one of my listeners wants to ask you a question? Are you up for that?
Absolutely.
How would they ask you a question? Or how could they contact you? What's your preferred message? So they go to your website, LaurenLeviMD.com, which is LAUREN Levi LEVI DMD.com, or is that how they should contact you?
That's
or
great.
Do you prefer email or phone?
They can email me at it's drlaurenlevy@gmail.com, but it's drlaurenlevy@gmail.com, so no period. Yeah, I mean, anyway, I guess.
And you're in Manhattan. Yeah. Do you think you'll ever grace us with the privilege of getting on?
I would love to do that. That would be great.
Oh, we would absolutely love it because this story just gets bigger by the day.
Yeah, absolutely.
Do you think it's confusing around the world on the internet where the Brits are calling it mouth cancer and we're calling it oral cancer? Is that why do they call it mouth cancer and we call it oral cancer? Or what do you prefer to call it? Mouth cancer, oral cancer?
The question is, which word do you think encompasses more, oral or mouth? What do you think? I don't know. What do you think? Do you think oral sounds more general than mouth?
I
think it might.
Well, I think that when I think of the 7 billion people, they might know mouth more than oral.
That's true, actually. So then maybe mouth is a better term. I guess my only thought process is that oral might encompass the oropharynx, thinking of the throat, but I guess if people are maybe people think of the throat more associated with the mouth. I
think the other human element side of the story, people are wondering is, how the heck did you get out of dental school and end up in oral oncology? Explain that journey. How did you get from doing fillings, crowns, and root canals to oral cancer?
That's a good question.
And wasn't that kind of picking a much harder road for yourself? You're dealing with life and death, and that seems like it would be a much more stressful job than someone who goes in the office and does fillings and crowns all day.
Right. No, it's definitely very different, but I feel like it's really rewarding. So I always liked oral pathology and oral medicine in dental school, but what I felt like was missing with at least, it's not fair for me to say what I felt like was missing, but what my concern was, it was like I was worried that if I went down one of those routes that I wouldn't be seeing patients that much and doing dentistry that much, like the actual, fillings and crowns. What's nice about dental oncology is it's really a fusion of both, that there is a lot of oral medicine and oral pathology associated, but you are still restoring people's mouths and getting them ready and seeing them after their treatment, during their treatment, and doing conventional dentistry. So it's a nice fusion. So I guess I did a residency at Cornell, and at Cornell you rotate through Sloan Kettering, and that's how I stumbled upon this.
And the other thing we haven't talked about any is oral radiology. As you know, when I got out of school, it was a pano. I'm so old that when I got out of school, the biggest invention in oral radiology was someone who figured out how to put an L on one side of the pano and an R on the other. And we just thought that was just, wow, that was a great idea. Now we have $100,000 CBCTs. Is that part of an oral cancer exam? Are CBCTs going to be a game changer for oral cancer, or is oral cancer really more of a soft tissue and not really bony lesions, and we're not going to be, are we going to be detecting more oral cancer because we have three-dimensional CBCTs, or not really? Is it mostly still a soft tissue disease?
It's still a soft tissue, but I wouldn't discount it being in the bone. So I think as technology gets better with imaging, that the more information that we can take, the better. Again, like it's not when people think of oral cancer, they're not thinking of bony manifestations, but absolutely, that's not something that should be ruled out.
And what percent of oral cancers would have a bony manifestation?
It's really not. You're not really. I think it's more concerning that it be metastatic disease to the jaw first than it being oral cancer that first started in the jaw, if that makes sense. So a metastatic, a met from breast cancer or prostate cancer going to the mandible. But that's not to say that oral cancer cannot manifest in the jaw. Unfortunately, mucoepidermal carcinoma can manifest in the jaw. And we know that there's a bunch of different cancers that unfortunately follow nerve paths and can also.
And now let's switch to the ugly part of the interview. Or when you see these face oral cancer, what is their life expectancy? I mean, are you just helping these people live a little more comfortable for the last year of their life? Or are they getting 2 years, 3 years? Do they ever get cured? What's it like on the dark side?
On the dark side, I think it's pretty good. I mean, obviously every patient is different, but a lot of times I think I'm seeing patients that, as long as you're seeing patients where they are diagnosed early enough, the survival rate is actually pretty high. It's when you catch it too late, that's when the concern is. But if you catch it early and they're being treated, then it's pretty good.
So are all cancers? I mean, it seems like I'm a dentist. I'm not an oncologist, but it seems like whenever you read about cancer, it's basically always 4 stages. Is that the standard deal? Like on a Google rating is 5 stars. Cancers 1, 2, 3, 4.
Yeah.
So walk us through the survival rate of oral cancer if it's stage 1, 2, 3, 4. I mean, if you pick it up stage 1, is it like going to be a very high chance living in stage 4, no chance you'll live?
I don't think it's no chance, but I think it drops to being like 50% if you're going to stage 3 and stage 4. But I think if you're catching it early, then, like I was saying, then the survival rate is significantly higher.
How come we always see articles in the press that say that oral cancer has seen no increase in survivability since it was first discovered in 1950? The problem with the internet is you got to figure at least 90% of all the stuff you read on the internet, it's got to be crazy.
Right.
And I try to stick with, trusted sources and that's another great question. What is a trusted source? Is WebMD, what are good websites for dentists to be learning about dental oncology?
So the NIH has a really good review of the basically of the dentist's role in cancer treatment, and if you see a patient before stem cell transplant, what to do. If you see a patient before head and neck radiation, chemotherapy, what to do. And it's very detailed, and I think that's great.
NIH.gov?
And I don't know if that's it probably .gov. Yeah, whatever the NIH website.
Is that also, that's the same as PubMed.com or PubMed? Is NIH the same as PubMed?
Is it the same thing? I don't know.
Okay.
I don't think so.
Okay.
It's basically if you type into Google cancer, dentist, NIH, then I think it'll come up. And then there's another one the NIDCR is pretty good as well. And they actually have a lot. That's more of a dental website, but they actually
NIDCR.
I think so.
Is that what you said? NIDCR?
Yeah.
National Institute of Dental Cranial Research.
Yes. Okay, that's exactly it. That one is great as well. I think I would take those two. I also really like Up to Date, but you have to have a subscription to that.
And how much is a subscription to that?
You
don't know?
I don't know. But that one is great. If you have some sort of institutional access or something, it's free. Most hospitals have Up to Date. It's great.
So how rare are you? I mean, how many dental oncologists are there in the United States? Do you guys have a national association or
we don't. It's a pretty small niche, and I think not that many people know about it. And I don't know. I mean, Sloan Kettering has a program. MD Anderson has a program. I think
MD Anderson, that's Houston?
Yes.
MD Anderson is Houston. Sloan Kettering is New York.
Right.
Mayo is Rochester.
Right. I don't know if Mayo has a program.
But that's about the only 3 people that the rich elite people from around the world go to for cancer, and it just those.
Yeah, I guess so.
I mean, if you got all the money in China and you get a bad news, you're going to go to one of those 3 hospitals.
That's true.
In fact, when I've lectured in 50 countries, and the saying goes in every country, if you get cancer, you don't need a doctor, you need a pilot to fly to America. And then when you get there, stop at either Sloan, MD Anderson.
It's true.
I've heard dentists say that to me so many times.
Yeah, I agree.
Yeah. So that must be a fun group of people you're hanging with.
Yeah, no, I mean, I think it's really a much more upbeat field than it probably sounds like. but I think you just have to have the right mindset. And what's great about it is that it's very rewarding and it really makes you appreciate life. You know, like, who cares that you woke up on the wrong side of the bed? The patient you just saw is battling cancer and, like, you know, he's happy, so you better, like, shut up and not complain that you spilled coffee on yourself. Something like that. Like, it really makes you put everything into perspective.
That must be very rewarding.
Yeah, it really is.
Yeah, and for me, every dental missionary trip, I remember the first time I did my first dental mission was in Chiapas, Mexico. When I was flying down there, I'm doing all this paperwork, and I'm going a million miles an hour, and I thought I had all these problems with my business and raising 4 kids. And then you get down there and see 5,000 people living with no electricity, and you're just like, okay, maybe I don't have a problem.
Exactly.
And maybe every patient you see, you're sitting there thinking, wow, I'm having a much better day than I might think I'm having.
Exactly. That's right. Exactly.
So how many dental oncologists do you think there are?
Well, the program at Sloan, there's 4 fellows every year. I'm not sure when it was founded, but I want to say it's been around for at least 20 years. So they are producing 4, and that, I mean, probably more than 20 years. I don't know, 30. I don't know how long it's been around. And then I don't really know the history of MD Anderson, but I think that also has 4 fellows. So,
I mean, just four every year, or just 4 period?
4 every year.
4 every year.
But it doesn't mean that
for a country of 1/3 of a billion people.
I mean, there's probably more. I'm sure there are other programs that I don't know about, and I think there are a few other programs that's spurting. Like, I think there's a program in Buffalo that just opened. When I Googled to look for other programs, it looks like just recently, because I also have this question, because we don't have an association or anything. It's, if patients are looking for someone that has dental oncology background in a lot of states, it's not so easy to find them.
Well, if you want me to, I got 50 employees. If you want me to create an association for you, I mean, build up a website or whatever, I'll absolutely do it, because it's just that important.
Yeah, no, it really is.
If you want me to do that, I'd be glad to, because oral cancer just seems to, I mean, it's the most serious thing in dentistry, and
absolutely.
And the fact that where 99% of everything you want to read about dentistry is always going to be a cosmetic veneer case on some beautiful person like yourself, and then 99% of the dentistry is not veneers and bleaching and bonding and all that stuff, and then here in your area, people are dying.
Right.
And,
no, you're right.
So there seems to be an inverse relationship between importance and press coverage.
No, I completely agree.
And who was that Buffalo football player? Was it Jim Kelly or who's the famous Buffalo Bills?
No, I think it was Jim Kelly, wasn't it?
Yeah, I think so.
I think so too.
Yeah. Have you heard anything about his case? I mean, is he gonna beat that?
I don't know.
You don't know? Yeah, HIPAA probably wouldn't allow us to say.
Yeah.
But anyway, so I just want to say, seriously, I think you're a rock star. I'm a huge fan of your website. I'm a huge fan of you, period. I think what you're doing is unbelievable. I really hope we put up about, I think, 327 courses on Dentaltown. They've been viewed over 500,000 times in all 206 countries. I think the world needs to see some online from you. I hope you put it up.
Absolutely.
And thank you so much for taking an hour of your important world and spending it with me. And thank you for all that you do for dentistry, and thank you for all you do for your patients. And it was just an honor interviewing you today.
Thanks. No, it was great. I'm really glad I did this. Thanks so much. And I love Dentaltown.
Thanks very much. All right. Talk to you later.
Okay.
Bye-bye.
Bye.